Do we have? Okay. I think has Dr. Abid joined? Okay. If not, we'll move on. So next, I would like to introduce our next speaker, Dr. Giridhar Gopal sir. Sir is a medical doctor from Tanjavur Medical College, 2005 batch. He has completed his master's in community medicine from AIIMS, New Delhi. Following this, he did his PhD in infectious disease epidemiology and health economics. His interests are data science, machine learning, and artificial intelligence, infectious disease modeling for studying vaccine effectiveness, and disease transmission models to inform mitigation and control strategies. He was one of the collaborators for COVID-19India.org and led another voluntary team for COVIDtoday.in, which were very famous during the times of COVID. He was one of the he's presently working in One Health Trust under Professor Ramanan Lakshminarayanan sir. With this very brief intro, I'd like to invite Dr. Giridhar Gopal sir to talk on the topic big data in healthcare. Over to you, sir.
Yeah, thanks, Venkatesh. I mean, I actually didn't expect, this kind of, crowd and speakers to come in. And to be honest, I mean, I really didn't know what kind of speakers and target audience I need to address this presentation to. But I tried to keep this, as generic and as, brief as possible so that it just gives a crux of what big data really means. And I'm sure that there are a lot of experts and people who have spoken before me know about this, but for the sake of the people who are coming in, I'll try to share what knowledge I will have. So everyone knows what big data is. I mean, data big, so the adjective itself says that it's a very, very big voluminous kind of data. But how data in healthcare can be very, really useful. Now that's where the big data boom and the kind of focus has come in. Right? Why do we need data in healthcare? So that's next question. So before we go into it, let me try to show some story and try to make it more interactive so that people get the context of what we are getting into. Because big data is a different territory, because it comes to a territory where clinicians need to think about data and inform their decisions, be it at a very patient level or at a clinic level or a hospital level or at a broader population level, right? So I'm just giving you a small story. My slides are not moving.
Your first slide is visible, sir, but slides are not moving.
Yeah. So, okay, so this is a picture now. We have like 3-4 people who are standing in, and as you can see, there is one supervisor on the left, there are some 3 people on laborers on the right. So it's just a small story. So let's see, the first lady, she just comes, hey, what are you doing? Right? So the first person says, I'm a bricklayer. I'm working hard, laying bricks to feed my family. And then she asks the same question to the second person. The second person says, I'm a builder. I'm building a wall. She asks the same question to the third person. And he says, I'm an organization builder. I'm building a great office space in which people will work on ideas for India's growth. Now, if you ask me, like all 3 of them are qualified similarly. They all are laborers. They all are, putting the bricks. They are building something. But the way that they see their work, the purpose that they find in their work is very different, right? Now, this is the question I want to ask all the participants in this meeting as well. Now, you will all be trained in doctors, you'll be MBBS, you'll be a medical professional, you'll be a surgical professional, you could be a super specialist, you could be anyone, right? But how do you see your profession? What purpose do you see it? Do you see it only within the territory of seeing patients, or do you want to create a bigger impact, to a group of patients or a community, or a much, much bigger impact, maybe at the district level or state level, even at the national level? So that kind of question is what big data is going to give you. Because to understand big data, that amount of thinking and the breadth of impact that you really wish to contribute is going to be very important to understand it. Now, coming to what big data is, it is actually, a lot of collations of different types of data. Now, here, this picture shows most likely the clinical ones, like you have claims data from insurance papers, you have mobile data and wearables, because that's the the recent hot throb or the kind of hot topics that come. You have the Apple fitness trackers, this tracker, that tracker, so on and so forth. You have some non-retail outlets as well, like you have some medical bills, or you have some specific NCD, kind of habits that can be tracked, where people can monitor their diet, they can monitor the food they eat, the calories they take, and all those kind of things. Hospital EHRs, electronic health records. Then you have some provider softwares, like, a lot of people have come before me who have spoken about softwares and how different softwares can be used to track, individual level data and all that. And then there are some systems wherein you have an opt-in genome registries. For example, people who deal with blood laboratories, or they do testing, the big, screening or something like that. They may store such kind of samples for biobanks, and it can then be, with patient consent, of course, can be opted in for genome kind of research. So basically, kind of a retrospective case control, or it could be something like essentially, some kind of cohorts wherein that this is the baseline characteristics of a population or individual. Given that baseline, what is the risk of someone to develop stroke or myocardial infarction, so on and so forth. Patient registries, this is something that few states have started doing it. For example, our state, Tamil Nadu, has started having an HMIS. You have the inpatient, outpatient records in it. You have the treatment that these patients take that is also being followed up. You also have the private payers and their claims. So private insurance players, the government health plans. You have the CM, health insurance schemes and all that, and the pharmacy claims. So all this data right now at this point in time is more of a clinical. But let me just add more, public health, a preventive health version to it as well. Now imagine a kind of a system like when COVID happened, you have contact tracing happening. It's a massive data. It's a massive data. Like people were tracked, people were quarantined, people were isolated, lab testing data. So, you have tests that been coming for pus cultures, you have tests that's been done for antibiotic sensitivity. So all these are all massive data. Now, all the data put together, it's all in different bits and pieces. Now, how do you do some inferences out of this data? How can you make some sense out of this data so that it can make some meaningful policies for your local clinic or for a broader population health is what big data really is. Now, let me go to some technical things, but again, just for one slide, but then we'll get back to the basic stuff. So big data is defined by different V's, right? There's so many, words that define a big data. Volume, of course, it's big, right? So that's the size of data. It could be in gigabytes or it could be terabytes when you take data at the country level or even in the regional level. The velocity, because some data need not be updated on a daily basis. Some can be updated on a weekly basis. Some can be updated on a month. Some can be updated in 2 months. Some can be updated only a year, right? So that velocity of updation, the quality of that updation, whether the standardization of the updation, people who are updating the data know what they're updating. So like, for example, I'm updating, say, antibiotic sensitivity sitting from Chennai. Venkatesh is sitting in Patna and he's, doing the same thing. But how I define antibiotic sensitivity, how Venkatesh perceives antibiotic sensitivity could be very different. So that velocity and standardization, variety, like how I showed in the previous slide, there could be lots of data. It could be different things, but you could try to find the links between it. Veracity, as I said, the accuracy and the way that which people define value, because you could collect a lot of data, but there is no point unless you don't have any value to it. So value of the data is also some measure that we definitely give for big data. Validity, which is the data quality, the governance. So essentially, that, okay, when initially me and Venkatesh and few others, we took training in, reporting in some reporting portal. But then beyond a month, there is no monitoring or evaluation in how that we have been filling the data. There is no governance. There is no system that tells us whether what we are doing is correct or wrong. So is that validity there? Variability, meaning there is different data sources. Now, all of you know very well that within the country, when COVID happened, each state had its own dashboard. Each district had its own dashboard. Each taluk had its own dashboard. So that kind of variability. And how can you guarantee whether each person and each administrator defines the same case the way that ICMR had given in the guidelines? It's very difficult. So that kind of variability is something that we need to do. Venue, there is something called GIS, GPS kind of tracking data that has come very recently. A lot of experts who are working it on geospatial programming and all that. Really, really good stuff happening around the world when it comes to tracking, whether vaccines have reached the farthest corners of the world, whether people living in the farthest corners of, the oceans or the mountains or the really, really hard to reach areas are able to get equitable access to healthcare and all that. So the venue. So such kind of data is also something that we really need to know. Vocabulary, meaning when all the data comes into one place, as a researcher, Do I know what I'm, doing it? Because I may get some data in Hindi, I may get some data in Arabic, I may get some data in Chinese, I may get some data in Portuguese. But at the end of the day, when I'm presenting it out to all of you, does it really mean the same meaning that it is supposed to be presented in? And then the vagueness. Because generally what happens is there are so many tools around. I mean, forget it. You have the R, you have the Hadoop, you have the Python. There's so many tools on. Let's leave it alone. But the vagueness is the beauty of big data, wherein you then try to understand, you can grade the data. Okay, now this data can be revived. We can do some, like how you do some cardiorespiratory resuscitation. You can do some reviving in the data. You can actually make it live. You can try to make it speak some truth out of it. Some data is really dead. There's absolutely no use in analyzing it or collecting it at all. But that vagueness has to be there. And that's the beauty of working with big data, right? Now, why do we need big data? And so this is the potential implications and use. So this is where we really come to the heart of the topic that I'm just given. You can go into diagnostics. For example, you have a lot of data that's coming in, which actually says that, okay, for example, a specific issue, malaria. Now for malaria, you have multiple, laboratories working in, multiple clinicians treating it, multiple patient records coming in through insurance or from patient records. Imagine you combine them all together. Now I can know what is the average time taken for this kit by this company to give a result. I could do that kind of sensitivity specificity testing, whether the kind of treatment given by the doctors, is it really accurate to what has been given by the testing kit? What is the average time taken by the patient to, return back to office, return back to school? So these are kind of things that as a, policymaker or as a public health physician, I'll be more interested to see. So I can improve the diagnostics. Rather than keeping cheap diagnostics, I could use more that could be sensitive, specific, and also more cost effective, right? So that's way I could actually, using big data, I can try to understand best diagnostics for my population. Preventive medicine, I'm coming from the preventive side, right? So we could try to understand, as I said, you could have a repository of people, understand their baseline characteristics, or you have a people of already diseased people. You can try to trend them and plot them across time, whether they follow the same risk factors and what are the chances of death, what are the chances of recovery, do they complicate, do they not complicate, do they recover, do they not recover? All these kind of things can be done. And that can inform policy, because every, action, ideally speaking, I mean, I don't know whether it's actually happening on ground. It has to be data driven. But sooner or later, there are so many other factors that could come in play, which could actually influence policy. But definitely, if data is good, and we know that each data can actually resonate to a good policy, why not use it, right? Precision medicine. Now, this could be very useful for, the clinicians in this meeting. I mean, you could be a GP, you could be a pediatrician, you could be an orthopedician, you could be, urologist, you could be any surgeon of any sort. Now, if you have a patient level database in your clinic, it will be very, very useful for you to understand that whether your medicines, your ways to treat patients, and whether the diagnostics that you've been using has been really good. At the same time, more useful if you're able to step up, going to the broader picture. If you have the patient level information, as I said, I mean, we are building repositories. So if you have the patient level information, you know which patient will respond better to your treatment, which patient will respond better to surgery, which patient will respond better to this medicine, X medicine, Y medicine, so on and so forth. So that is the kind of beauty that big data can come put forth to you. Medical research, of course, there's so much of ocean when it comes to data-driven research. You could try to build, artificial intelligence and machine learning algorithms. Now, these are things that have started to come in the last 3-4 years. Now, I'm a medical doctor. I'm starting to learn about it. But just to give one single idea of how machine learning and AI has been really, really transforming things. Now, you can just imagine in countries like Korea and China, apart from this data, they've actually been following patients or people who have been isolated or quarantined through their CCTVs, through their GPS locations, through their mobile credit card and debit card swipes, through the retail purchases. So, it's like essentially using, the complete potential of data and trying to link how COVID-19 can be controlled. Now, if you see zero COVID policy in China, it may not be successful, but how they implemented it, the way that they thought, but it had its own challenges because it will be infringing in people's privacy, which is a topic that we can discuss sometime later. But that is the kind of thing that, big data, machine learning, and AI can bring into picture. At the same time, it can also give and identify patterns within the data through which we can understand, okay, this set of people are actually at higher risk. This set of people have some hazards to, show some disease presentation in a given period of time. Then it as a drug or any pharmacy or a general physician practicing in the clinic, you can actually monitor which drug is actually creating adverse reaction in your population. Now it's very simple. Now, even if you take some simple antibiotics, now few people may react, few people may not react to it. Now who will not, all these kind of things you can actually find, because if you are actually dealing with a specific geographic population, you may be rest assured that, okay, I'm giving this, people are cured and they are going up. But if you try to follow them up a little, one step higher, a little uncomfortable than your regular practice, you try to follow up all this data, you will make sense of what is actually meaningful and what is actually being very useful for the population. Cost reduction. Again, when you're practicing, you will have same kind of patients, but you will be trying to understand how much different things I can do, what different therapies I can make, should I try this treatment, A plus B? Should I try C plus D? Should I try P plus Q? So all these kind of combinations, you will understand which is actually more beneficial, less costly, and that point in time, you can also get better name when you're doing your clinical practice, and that can actually ensure that people also know that, okay, you are very patient centric and not like totally corporate or something like that. It's good to earn money, of course. I'm not denying on that regard. But at the same time, when you try to think from the patient's perspective, you always tend to earn more respect and trust in the long run, because that's ultimate customer satisfaction, right? And finally, of course, population health. So I have covered a lot, so I'm just going to next. Now, this picture I'm showing just next to you, you might wonder, why is Dr. Gopal showing this? So is medicine a science or an art? So essentially, earlier days when we didn't have much research happening, it used to be intuitive. But that intuition was driven by experiences. And those experiences were some data, some observations. So when we actually translate these observations and intuitions into science, so the art and science then mingle together. So essentially, a person who is actually driven by good research and good journals, like whatever Harrison's you read, whatever Davidson's you read, whatever Schwartz, or all the books that you read, they all have come from repeated trials or repeated evidences that have been collated over time that have actually meant meaningful outcomes for the patients, right? So such data makes the art like a science. And the more you get exposed to such kind of data, you slowly become, I don't have to refer them, I know them already. So then it becomes an art because it becomes a part of you. So that's how medicine is, right? And then using big data in healthcare, ideally it needs to be integrated. But the unfortunate issue with big data is that each domain is vertical. People don't want to collaborate. It's like, okay, I'm the owner of the data. Why should I give the data to him? I would like to publish my data, because I'm a lab lead, but I would not like to link my data with the hospital. But when you link it, it becomes more meaningful. But then the ownership and the publication rights and all these things come into picture. And of course, the privacy issue of patients, health ownership and all those kind of things. Then, as I said just a little while ago, we need to enable collaborations and knowledge building. Now, because this is a forum for IMA, I can just give you a very simple thought. Now, imagine in IMA, there's a district in Tamil Nadu, say Tanjavur. I'm from Tanjavur, right? And let's imagine there are some 100 practitioners there who are doing their general medicine practice. Now, imagine all these people put their data together and they understand what is the kind of antibiotic that is sensitive for UTI. What is the kind of drug that is being useful for, say, peptic ulcer? What's the kind of drug that's being useful for MI? Now, all these things come together. It can actually help to understand the kind of treatment practices that could be beneficial, that may not be beneficial, both for clinical practice as well as for the patient. Now, such kind of collaborations rarely happen, but I strongly, suggest and recommend IMA could try to think in those terms, wherein you could build systems within IMA, wherein data sharing between clinicians using some softwares or anything of that kind could be made, so that such kind of meaningful partnerships can be made so that doctors can also enjoy the practice of medicine and meaningful practice for an outcome for the patients as well. And then I strongly believe, and this is some words that I have heard from my previous mentors, anything in the world can be processed, right? I mean, you can break each and everything that happens in clinical practice into process. Each process, if you make, you can actually quantify that process. And when you quantify a process, you get a date, right? So big data can actually help and ensure that whether whatever mechanisms and whatever therapies and whatever kind of treatment guidelines or programs that are happening, are they happening the way they should be? Are they not happening the way they should be? So you can actually monitor and evaluate whether things are going right or wrong. So that kind of comparisons within the program, you could do the comparisons between districts, between states, between countries, so on and so forth. Then streamlining. So if a process is not good, you could streamline them, you could make them more efficient. Thus, at the end of the day, all the big data, whatever analysis we do, whatever kind of technology we speak, it all boils down to good patient outcomes, a very good and healthy population that can actually contribute to better economy for the country. And then, as specified earlier, we could detect patterns in data. Last but not the least is a decision making by context. What do we mean by context? Essentially, we all, go to papers that have been published in Lancet or the NEJMs. There could be something in, for surgeons or pediatricians. I'm not very aware of it. But those studies have been done within the context, meaning they've been representative of that specific population. It could be England, it could be Germany, it could be United States of America, it could be Japan, it could be Korea, it could be anything. But to understand whether such decision can actually be applied, can be useful for the population within your area, within your practice, it will be very useful if you have such big data access. You could easily try to analyze the same variables, that particular studies have done, and you could do a retrospective analysis, whether it is really useful or not. And I'm not speaking on a publication perspective, but even for practice, this can be very, very, very revolutionary, and it can guide clinicians to much, much better, context-specific treatments. Now, coming to One Health Trust, because we're speaking about big data, I thought I should mention a few projects that have been working in big data, so that could actually give a sense of what big data it is. Because rather than speaking on big data and rambling about the different technologies, I thought let me keep it very superficial. So the first project that I would really like to bring on is the antibiotic resistance map. It's something wherein we are actually tracking the antibiotic use across all the countries in the world, and we're also tracking the resistance patterns of WHO priority pathogens in all the countries. Again, subject to data availability, but it's there in our website. It's a yearly, monthly kind of exercise. It has its own challenges because, we had to bring all the different reporting, different languages, different types of data, different frequency of data into one format. So that's there in the website. We are working presently on a medical oxygen grid for the country. Right now, we are planning to pilot in Karnataka and Uttar Pradesh. So you can imagine, so you need to bring a lot of data from different private, public players, the supplies of oxygen, the supply logistics of oxygen, the pressure monitors. So there's enough indicators and data that we need to bring together and standardize. So that's again one example of a big data project that we're working in. There is a population level screening of individuals for NCDs and risk factors that we have actually been doing in our campus, which I'll be mentioning in a few slides from now. We are building a demographic surveillance system. So we are actually tracking patients on their lifestyle factors, on the dietary factors to ensure whether that they will develop a disease. Is there a risk factor disease? Then we will give some interventions and something of that sort. Coming to the One Health Surveillance platform, I'll again explain what it is, why we need it, so that it gives a kind of perspective to you in just next slides. Biorepository, wherein we are making samples of different patients, wherein you can actually compare the blood samples taken today and compare the blood sample taken after a year or two and see how much of all these parameters have changed with time, given the risk factors that these individuals had, whether they're prone to develop MI, whether they're prone to develop stroke, whether people really benefit from interventions or not. All these things can be tested. We are also working on point of care device through a sister company. There's one organization under Dr. Ramanan by the name HealthQ. It's a point of care device where we are training entrepreneurs to go home to home on an incentive-based model, wherein we are actually collecting a cloud-based data of patients who need to be followed up for diabetes, newly diagnosed diabetes and hypertension, and also some simple tests for anemia screening as well as for pregnancy tests. We have been training entrepreneurs across the state and across the country. Maybe like close to 1,000, 2,000 entrepreneurs have been trained under us. And last but not the least is the Global Pervasive Computational Epidemiology Network. We are a part of it, and we have been supporting this network with a lot of data from different countries, so we can understand how disease presentation have been changing with time, how pathogens have changed with time, because pathogens are also evolving, humans are evolving, right? How my father used to be, I'm different, my daughter is much different. So likewise, even a pathogen tends to change with time. Its resistance changes with time. How it handles antibiotics, how it handles anti-malarials, antivirals will change with time, right? Climate change is a very burning issue. I'm just coming next to it. And of course, vaccine effectiveness. When you test a vaccine, it could be super effective, but moving forward, the pathogen just changes and adapts. So all these kind of models and all these kind of things will require intense collaboration between community data, hospital data, lab data, and the research data coming from the vaccines. So we can just try to understand how these things can happen and predictions can be done in a much better manner so that policymakers can understand whether investment needs to be made or not made, right? And then just to give an example of how climate changes. So far, all of us have been speaking about human health, right? Now just see how this is. Now the point one, global warming raises the ambient climate temperatures. And because of this, select set of fungal organisms, they start to reproduce in avian and mammalian basal temperatures within the body, right? And then what happens is Candida auris was previously, it was a saprophyte. And then it started to gain thermotolerance because it started adapting given the global warming. Salinity tolerance started happening because of the climate change, and its ecosystem changed. Why? Because the thermotolerant Candida auris, it started to migrate because earlier it was very deep in the water, but because the water body started drying, the Candida auris came to the top, and the migratory birds took this Candida auris. It flew to the cities, to the peri-urban areas, and then it got in touch with the chickens and the poultry farmers there. There were interspecies transmission, and from there on, it goes to the cities, then hospitals. Can you imagine Candida auris has a CFR of 40%? That's the kind of scenario that we are creating in the world right now. So climate change is one example, but to actually understand this kind of a transmission pattern, I would need data from the climate, the meteorological department data, really, really specific over years, over months, over weeks, how all the environment, the water bodies are shrinking, water sample data from different bodies, going to the farms, animal level data, whether that kind of interactions happen, patient level data. Now, this is big data. Now, you see how you could try to understand one issue of climate change and its impact on changing the virulence of a not so called pathogen, because Candida auris was not at all present 20, 30 years back. But now it is slowly starting to show its prevalence in hospital settings. Why? Because climate change is happening. Now it's easy to say, hey, you have to control pollution. Hey, you have to do this. But this kind of collaborative data analysis, packaging, and showing it to a policymaker can make a lot of sense. And this is what is the strength of big data. And this is the One Health that I was trying to show you guys, because at the end of the day, when we were previously working in CDEP, we realized human health is not unique. At the cost of animals and environment, we cannot live happily, we cannot live healthily. Human health and animal health is interdependent to the environment we live in. And these kind of intersections and these kind of relationships are something that we cannot disregard, we cannot disrespect. And that is the price that we are paying these days because of COVID-19 or the Candida auris or antimicrobial resistance and so on and so forth. So this is what we would like to show you, that whenever we do a research, I'm giving it in an infective disease perspective, but even for NCDs also, the environment is very, very essential. For example, why would someone go and smoke if there is so much of smoking or alcohol shops or fast food items within the vicinity? So there is a civic sense, there's a kind of civic responsibility for the urban planning bodies to understand how much of risk factor can be kept. But when you just shoot it out, then there's of course no monitoring. So that's the reason why, we'll always need to have this balance between humans, animals, and the environment. And lastly, just to mention about the work that we're doing on the surveillance side. So this is something called the in-depth surveillance network that's been happening in the world. Right now, there are 52 HDSs, which means human demographic surveillance systems, right? And they are present in all these places that you see in red. But none of these sites focusing on One Health surveillance, where animals and environment need to be given the right weightage and respect. So for the first time in the world, we have actually been starting this One Health surveillance site in a catchment area in Chikbellapur. It's a little above Bangalore, like an hour's drive from there. So all the activities that you see, wherein we are trying to collate the population level screening, we are trying to do the animal health mapping, the environmental sampling, all these activities are happening there. We are coming up with the campus there. All this big data will inform policy to the government of Karnataka to ensure that they could do at least some state-specific policies. Now, whether this is going to go to a national level or a world level is secondary. But the idea of big data is always to create the change, the theory of change. Can you be that initiation for that kind of change, so that the thinking starts into the health fraternity and the professionals who think, yeah, we are all good, we are all great. I mean, there's no problem. But understand that we are at the mercy of our planet, we are at the mercy of our animals. So we cannot take them for granted. So these kind of data and longitudinal data that we would like to follow. Humans, animals, and all that. New evolvement of patterns like corridors and so on and so forth. And this is all about big data. And this is one other project that we've been doing, wherein we have collected data from close to 30 countries, around 170 indicators, same challenges, different governances, different data cleaning, different languages, different methodologies, different frequencies, yet we bring them all together in one place. So we have a team of good data scientists. We have a good team of machine learning experts. We're also working on prediction analytics to understand whether the kind of inputs that these countries have been making are really translating into good health outcomes at the population level or not. So this kind of work has also been happening. This slide, which I always humbly follow, the fool who knows he is a fool is that much wiser. Generally, I mean, how far ever you go in your life, at the end of the day, we should always remember that we are children to God, and there is nothing that, we feel that, okay, we know everything, we are the, the bosses of everything, we might be the best gold medalist, we might be from the best universities of the world, anything. But the more simple and more humble you are, the more chances of you to actually try to learn and do something new. You can be that entrepreneur that, I've heard seniors and experts and, leaders speaking before me. And I'm so privileged to speak in this panel. And any questions, I'm so happy to take. My email ID is gopal@onehealthtrust.org. And we are more happy to, exchange ideas and seek more collaborations and clarifications and research opportunities. Thank you for this opportunity.
Yeah, thank you so much, Girdhar sir, for this wonderful session. You have sensitized all of us on a emerging and important concept, that is big data. Thanks a lot.